Good morning, I am Dr. Muhammad Mamdouh, lecturer of nephrology and internal medicine. Now we are going to talk about vital colors during general look examination. What's important for us is pallor, jaundice, and cyanosis. We examine these vital colors in the skin, especially in the face, and bone and nails, and the mucous membrane in the inner surface of the lower lip and the undersurface of the tongue, especially in cyanosis, and also in the sclera and inner surface of the lower eyelid in jaundice. Pallor is loss of the usual color of skin, more evident on the face, palms, and the inner aspect of the lower lip. Causes of pallor include causes inside the blood vessel like anemia, which is the most important cause of pallor, hypercholesterolemia, causes in the blood vessel like vasoconstriction, arterial thromboembolism, or causes from outside the blood vessel like edema, obesity, and hypothyroidism. It will thick skin and decrease less visibility of the oxyhemoglobin. Cyanosis bluish discoloration of the skin and mucous membrane due to increased amount of reduced hemoglobin or deoxygenated hemoglobin in the capillaries above 5 gram per deciliter. Remember that hemoglobin is in gram, not milligram. Cyanosis is less apparent in anemia because in anemia there is decreased hemoglobin, of course, and is exaggerated in polycythemia. Cyanosis might be peripheral or central. Peripheral cyanosis is cyanosis which is present in the peripheries only, like in fingertips as we see here, and fingernails and toes, and tip of the nose and ear lobule. This bluish discoloration. It is mostly due to decreased blood flow and the stasis of blood. As we know, physiologically, there is continuous circulation of blood. Continuous circulation, the oxygenated blood will go to the cells, and cell will take oxygen to do aerobic glycolysis and do its work, and then the hemoglobin will become deoxygenated and come back through the venous blood supply to the heart, and then to the right side of the heart, then go to the lung, oxygenated, and then go to the left side of the heart, go through the aorta to the body again to give oxygen to tissues. But when there is decreased blood flow, there is a stagnation of blood and stagnation of deoxygenated blood. There is stagnation of deoxygenated blood which will cause cyanosis, peripheral cyanosis. So in any cause of decreased blood flow, general cause like in shock, heart failure, or decreased cardiac output, there is decreased circulation, decreased movement of blood in the circulation will cause peripheral cyanosis. Or there is local decrease in a certain area like in peripheral vasoconstriction as in cold exposure or Raynaud's disease, or there is arterial or venous occlusion, which cause peripheral cyanosis. What is Raynaud's phenomena? It is a spasm of the arteries followed by cold and relieved by warmth. There are 3 stages of Raynaud's phenomenon. At first, it becomes white due to vasoconstriction. Then the fingers will be blue due to accumulation of the deoxygenated blood. And finally, the fingers will go red due to reactive hyperemia. So at first, there is vasoconstriction, of course, pallor, white, and then there is accumulation of deoxygenated blood, turned blue, and then it becomes red due to reactive hyperemia. This is Raynaud's phenomena. Central cyanosis, when there is bluish discoloration all over the body, peripheral and central. Central, we mean mucous membrane in the lips or the tongue. There is cyanosis in all the general circulation. There is deoxygenated hemoglobin in the systemic circulation. The cause might be, as we said before, the blood will get oxygenated again in the lung. So if there is a defect in the lung causing decreased oxygenation, this will cause cyanosis, will cause increased deoxygenated blood. If there is a problem in the heart, or there is a shunt connecting the right side of the heart with deoxygenated blood to the left side of the heart with oxygenated blood, there will be deoxygenated blood in the systemic circulation. Or if there is abnormal hemoglobin, which like in cases of methemoglobinemia. So causes of central cyanosis, is right to left shunt in the heart in congenital cyanotic heart disease. Defective oxygenation in the lung, any severe lung disease might cause central cyanosis, and abnormal hemoglobin as in case methemoglobinemia. As regarding this hypoxia, the patient might have polycythemia and clubbing. How to differentiate between peripheral and central cyanosis? Peripheral cyanosis will be present in peripheral circulation as we described before in the nails and tip of the nose and tip of ear, while central cyanosis will be present in the peripheral circulation and central circulation, and to detect central cyanosis we ask the patient to elevate his lung and look at the base of the tongue. There will be bluish discoloration. In peripheral cyanosis, the extremities will be cold due to decreased blood flow, while in central it will be warm. Peripheral cyanosis will decrease or disappear by warming and exercise. Why? Because we are increasing the blood flow. When the patient gets warm, we increase the blood flow, so we move away the deoxygenated blood back again to the heart. Exercise the same, we increase the peripheral circulation. While in central cyanosis, exercise and warming will have no effect. On the contrary, oxygen supply will improve central cyanosis. As we described, central cyanosis due to defective oxygenation centrally, either in the lung or the heart. So giving oxygen to the patient centrally, to the lung, especially if a lung cause, will improve central cyanosis. While in peripheral cyanosis, giving the patient oxygen inhalation will have no effect, mostly because the cause of peripheral cyanosis is defective blood circulation at the periphery. At peripheral cyanosis, there will be no clubbing or polycythemia, but in central cyanosis, we might have clubbing and polycythemia. In peripheral cyanosis, oxygen tension is normal, while in central cyanosis, there is hypoxia and defective oxygenation of blood. Jaundice. Jaundice is yellowish discoloration of the skin and the mucous membrane due to increased total bilirubin more than 2 milligram per deciliter. 2 milligram per deciliter. Normal bilirubin is from 0.2 to 1 milligram per deciliter. From 1 to 2, it is called subclinical jaundice. Jaundice will become clinically evident mostly when the bilirubin is more than 2 milligram per deciliter. It is best seen in the sclera in daylight. To understand jaundice or increased bilirubin, we should know the metabolism of bilirubin. At first, there is breakdown of RBCs, which is formed of hemoglobin, heme and globin. Globin will be degraded to amino acids. Heme is it consists of iron and biliverdin. Biliverdin will convert to bilirubin. Bilirubin will bound to albumin and go to the liver to become conjugated. In the hepatocyte, bilirubin, or what now it is called indirect bilirubin or unconjugated bilirubin. Indirect bilirubin or unconjugated bilirubin. Most important to remember that unconjugated bilirubin is fat soluble but not water soluble. What is meant by that? Fat soluble, it means that it can bypass the blood-brain barrier and cause kernicterus. And it is water insoluble, it means that it does not present in urine. So unconjugated bilirubin will not be present in urine because it is water insoluble. Unconjugated or indirect bilirubin will go inside the hepatocyte and get conjugated inside the hepatocyte and excreted as conjugated bilirubin or direct bilirubin. Is excreted through bile. It will go through the bile, through the common hepatic duct with the cystic duct, through the common bile duct to the second part of the duodenum, and in the intestine it has 3 phases. It will be converted to stercobilinogen and then to stercobilin and excreted in feces, and stercobilin is responsible for the color of feces. Also another portion will be reabsorbed as urobilinogen and will go to the kidney and excreted in the kidney. So urobilinogen is excreted in the kidney. And third part and third fate for the direct bilirubin is there is enterohepatic recirculation. It is reabsorbed from the intestine back to the liver to be part again from the metabolism of bilirubin. Causes of jaundice might include There is increased breakdown of RBCs at first, so it is called hemolytic jaundice, increased amount of hemolysis, increasing hemoglobin. Heme will increase more bilirubin, and it will be more than the capacity of the liver to become conjugated. So the bilirubin increased here will be consisted mainly of indirect bilirubin or unconjugated bilirubin. This is present in hemolytic or pre-hepatic. Inside the liver, if there is a problem, as we said, in the hepatocyte during conjugation, there is called hepatic jaundice, and sometimes we call it cholestasis. Cholestasis, it's meant by what? In that there is conjugation. After there is conjugation in the liver, it cannot reach the duodenum. It might be the cause due to causing that obstruction or inability of the bilirubin to reach the duodenum, that it might be intrahepatic cause, that there is abnormality inside the liver, like in cases of hepatitis or primary biliary atresia, and some in extrahepatic causes of jaundice, like in causes of obstruction by stones, gallbladder stones, or stones going to in the common bile duct, or cancer pancreas. This is extrahepatic causes of cholestasis. So causes of jaundice are either pre-hepatic due to increased hemolysis and increased production of indirect bilirubin, or might be mixed inside the liver due to inability of the liver to conjugate adequate conjugation of the indirect bilirubin, or the conjugation is done and there is failure to reach the duodenum. This is obstruction, and this obstruction might be inside the liver or outside the liver, intrahepatic or extrahepatic, and it is called cholestasis. And in cholestasis, the main type forming jaundice is direct bilirubin. As we said, unconjugated hyperbilirubinemia, usually it will be a lemon yellow. There is excessive urobilinogen in urine, and the stools will be dark. Stools will be dark because there is increased hemolysis in the liver. There will be increased conjugation, increased amount of conjugated bilirubin reaching the intestine, and there is increased stercobilinogen. Stercobilinogen will do stercobilin and will make the stool more dark. So in hemolytic jaundice, stool will be dark, and there is what will appear in urine in hemolytic jaundice or unconjugated hyperbilirubinemia, urobilinogen, because there is increased amount of bilirubin reaching the intestine, and there is increased amount of urobilinogen absorbed and going to the kidney, and it will be present in the urine. In obstructive jaundice, it will be very severe form. It is generally considered a severe form of jaundice, greenish yellow in color, dark urine due to what? The presence of conjugated bilirubin. Conjugated bilirubin or direct bilirubin is opposite to the unconjugated. As we said before, unconjugated or indirect bilirubin is fat soluble but water insoluble. But conjugated bilirubin is fat insoluble but water soluble. What is meant by that? That conjugated bilirubin is water soluble, that it can be excreted in urine. So if in the case of obstructive jaundice, when there is increased conjugated bilirubin, we will find conjugated bilirubin in urine. But because in obstructive jaundice there is obstruction and inability of the bile to reach the duodenum, so it will be decreased stercobilinogen. Stercobilinogen will not be formed because bile didn't reach the intestine. Stercobilinogen will not be formed, and stercobilin will not be formed, and the stool will lose its color. So in obstructive jaundice, stools will be pale. And due to absorption of bile salts, in obstructive jaundice we might have itching, bradycardia, and frothy urine. Thank you. Good morning, I'm Dr. Muhammad Mamdouh, lecturer of nephrology and internal medicine. Today we are going to continue our examination, general examination. We will talk about face and neck veins examination. Face examination, what is important for us to comment is vital colors, pallor, jaundice, and cyanosis, features, eyelids, and eyebrow, nose, and mouth, lips, and tongue, and skin, and muscle, and salivary gland. As we see here, during this phase, this coccynoid phase, this acromegalic phase with elongated lower mandible and enlarged nose ear, as we see here, prominent maxilla, and this is uremia, patient with chronic renal failure and with that earthy look due to abnormal pigmentations in renal failure patient. Eye examination, this is what is present in cytotoxicosis, staring look, and this is in myxedema, there is puffy face and dry skin. Also, we might find xanthelasma due to accumulation of cholesterol, and we might subconjunctival hemorrhage as in cases of hypertension. We might find periorbital edema, as we see here. Most important causes of periorbital edema is nephrotic syndrome and renal edema, allergy, and any cause of generalized edema might cause periorbital edema. An eyebrow, when there is loss of eye, we find that loss of outer 1/3 of the eyebrow is present in case of leprosy and myxedema. Fundus examination is important for us, but it's usually done by the ophthalmologist to detect diabetic retinopathy, hypertensive retinopathy, and in cases of retinal pulsations in aortic regurg and retinal artery embolism. Mouth examination is very important for us to detect the vital colors, as in cyanosis and pallor. And ulcers, this is aphthous ulcers, which is painful. This is oral ulcers in Behçet disease. Also in mouth, we should comment on the gums and teeth. As we see here, there is dental caries, dental hygiene, poor dental hygiene. Here there is gum bleeding, and here there is gum hypertrophy. It's common as a side effect in some immunosuppressive drugs, especially cyclosporin. Also, we might find signs of vitamin deficiencies, as here there is angular stomatitis at the angle of the mouth, or chylosis, look at this lip, chylosis, or atrophic glossitis, look at the tongue. Also for the tongue, we might find candidiasis, characterized by this whitish plaques present material over the tongue, geographic tongue, or strawberry tongue and vitamin deficiencies. Skin of the face, we should look for pigmentations, either hypopigmentations or hyperpigmentation. Rash, including vesicles, macules, and papules. Acne. Also, we should look for petechiae, purpura, and ecchymosis. Malar area, it is that area, the area of the cheek over the maxilla. This is the malar area. Very important, if you find pigmentations in the malar area, you should think of mitral stenosis, it's called malar flush, systemic lupus erythematosus, dermatomyositis, choloasma of pregnancy, pellagra, and sunburn. These are the causes of malar area pigmentations. Muscles, we should comment on the muscles of the face, especially if there is wasting or not. As you look here, there is wasting of masseter muscles and pterygoids. Salivary gland, if there is enlargement of salivary gland or not. Look at here, there is enlargement of the submandibular salivary gland. Here there is enlargement of the parotid, and causes of parotid enlargement include liver failure, mumps, sarcoidosis, Sjogren syndrome, chronic nutritional insufficiency. Now we will go for neck veins examination. Jugular veins are directly connected to the right atrium through the superior vena cava. So we are examining neck veins to detect pressure changes in the atrium. It is preferred to comment on the internal jugular vein over the external jugular vein. So the internal jugular vein is preferred. Why? Because the external jugular vein might contain valves and it might be obstructed during its passage during fascia and muscle layers. So internal jugular vein is better. But on the other side, the external jugular vein is easier to visualize. As you see here, This is the external jugular vein, and this is jugular veins. Here it is the internal jugular vein with the going to for the subclavian vein, which is then going for the superior vena cava and right atrium. Important to know veins or waves of venous pulsations. In the neck veins, we are commenting on the waves of it is wavy movement, and we should know waves of neck veins pulsation. It is abbreviated as A, C, X, V, Y. Most of you don't like to examine neck veins because you don't understand, and I will try to make it simple. To understand these waves without memorizing it, you should know it when you understand them. We will begin remembering our cardiac cycle and what happened in the cardiac cycle step by step. To go, we will start from here. We'll start from here. C, it denotes tricuspid closure. When the tricuspid valve is closed, we will discuss variations and what happened in the atrium. Because we are in neck veins examination, we will describe pressure changes in the atrium. So C is tricuspid closure. C, closure. After the tricuspid is closed, what happens in the atrium? It will be relaxed. So X is atrial relaxation. After the atrium is relaxed, what will happen for it? Atrial filling through venous return. So the tricuspid is closed, then what happens next? The atrium will be relaxed and it will receive blood. And after the atrium is filled with blood, what will happen? It will push blood to the ventricles. And as we talked before in physiology, blood will go to the ventricles 70% by gravity, so it is Y, wave, passage of 70% of blood in the atrium by gravity, and then the remaining 30% are pushed by atrial contraction. It is the A wave. It is the A wave. Again, it will begin by C, closure of tricuspid. It is followed by atrial relaxation. The atrium will relax. Then the atrium will get blood, atrial filling. And then the blood will go to the ventricles, 70% by gravity. And then A wave, the remaining 30% are pushed by atrial contraction. After that, there will be closure of tricuspid and the atria will relax. It receives blood, passage to the ventricle 70% and the remaining 30% by atrial contraction, and this will repeat. Don't memorize, but understand. When it is understood, it will be very easy. Okay. How to examine neck veins? The patient should be relaxed and we should raise the bed at 45 degrees. We shouldn't use pillow. Should be good lightening. We should examine tangentially. Internal jugular vein is better than external jugular, as we described. Right side is usually better than the left side, and we should comment on whatever when we see clearly or not. What are the items to comment during examination of neck veins? It is either congested or not, amplitude or congestion or the level of congestion or jugular venous pressure. It is pulsating or not, relation to respiratory cycle, hepatojugular reflux, relation to cardiac cycle, and special character if there is a special character in neck veins pulsation. First, we should comment it is congested or not. As we see here, for that neck vein, it is congested. Here, congested. Type. If we cannot see the neck veins, we might do some things to make it more clarified. We might compress the root of the neck to fill the vein. We might ask the patient to strain. We might compress the right upper quadrant, and we might lower the bed As we said before, the bed should be at 45 degrees. But if it is not visible, I might lower the bed and the patient lies flat, and then neck veins will become more obvious. How to measure level of congestion or the jugular venous pressure? The patient is present at 45 degrees, and then look at here. We put a ruler at that degree, at 45 degrees, at the level of the sternal angle, which is the junction between the manubrium and body of sternum. At that point, the distance from the right atrium is 5 centimeter. So any level of congestion, we are here at the sternal angle. We put a ruler here at the sternal angle, and then we look for the upper level of congestion of the neck vein. This neck vein is congested up to here, and then we put a paper to the ruler from here to here, and we look for the number on the ruler. If it is here about 3 centimeters, so it is 3 centimeters above the sternal angle. What is the jugular venous pressure? It is 3 centimeters above the sternal angle, and we will see how to do that on clinical examination on the patient. Here we put the ruler at the sternal angle and look for the neck vein and get the upper level of congestion, and we look for the ruler by paper, and we tell that there is 3 centimeters above the sternal angle. What is the normal value for the jugular venous pressure? It should be below 3 centimeters above the sternal angle. Less than 3 centimeters. If it is more than 3 centimeters above the sternal angle, so it is congested neck veins. It is not normal. It is congested. When I said it is congested, or when the jugular venous pressure is elevated, when it is more than 3 centimeters above the sternal angle. At that point, what is the actual pressure inside the right atrium? As we described before, at 45 degrees, the distance from the right atrium to the sternal angle is 5 centimeters. So if I have 3 centimeters above the sternal angle, so the pressure in the right atrium is 8 centimeters. So every measurement above the sternal angle will be added to 5, because 5 is a constant distance. If I found a pressure on the ruler, the congested neck vein was up to here, and then I measure on the ruler, it is about 5 centimeters, so it is 5 centimeters above the sternal angle, it is congested. And what is the exact pressure in the right atrium? 5 centimeters above and 5 centimeters below, so it is 5 plus 5, it is 10 centimeters inside the right atrium. It is in centimeter water. So second item to comment, the level of congestion or the jugular venous pressure. As we described, normal jugular venous pressure is less than 3 centimeters above the sternal angle, and it is meant that it is less than 8 centimeter water. When it is more than 3 centimeters above the sternal angle, it is called high jugular venous pressure. It is present in case of heart failure, or tricuspid incompetence or regurg, cardiac tamponade, constrictive pericarditis, or volume overload. In these cases, the heart will not take the blood from the neck veins. Will go to the heart, and it will find in heart failure the heart cannot pump, so it will go back to the venous side. It will increase the neck veins. In tricuspid regurg, it means that the tricuspid valve will not close properly. So during venous ventricular contraction, it will push the blood back to the right atrium and back to the neck veins, making it more congested. Cardiac tamponade, there is pressure in the pericardium, compressing the heart. So when the neck veins pushing the blood to the heart, the heart is compressed. It will not accept the blood. It will go back to the neck veins. It become more congested. The same idea in constrictive pericarditis. The heart cannot relax, cannot accept more blood. So the blood will go back to the right atrium and neck veins, and it will become more congested. In cases of volume overload, when there is increased more fluid in the patient, inside the patient, of course, neck veins will become congested. But if I found that blood pressure is just above the clavicle or about 1 centimeter above the sternal angle, it is meant that it's low jugular venous pressure. It is present in cases of hypovolemia. In cases of hypovolemia, there is decreased effective blood volume inside the circulation. So the jugular, of course, the neck veins will be collapsed. Third item to comment is these neck veins are pulsating or not. Of course, in most of the cases, it will be pulsating. Any cause congestive heart failure, tricuspid regurg, cardiac tamponade, constrictive pericarditis, in all these cases, it will be pulsating. But what if I find that it is not pulsating? I find that congested neck veins, it is not pulsating. It is present in cases in jugular venous obstruction or superior vena cava obstruction. And the causes might be malignancy or hypercoagulable state or previous catheterization to the neck veins. It might cause thrombosis in the neck veins, causing obstruction, and at that point, it will not be pulsating. It is also important to differentiate between venous and arterial pulsations. Venous pulsations are usually lateral to the sternomastoid muscle, while arterial pulsations are medial to the sternomastoid muscle. Venous pulsations in the neck veins are usually wavy, as we described before, while in arterial it is a single wave. Venous pulsations are better seen, but arterial pulsations are better felt. Venous pulsations change with position and respiration, or pressing the root of the neck, or pressure of the right upper quadrant change or increased, as we will describe. But arterial pulsation will not be affected by either of these. Relation to respiration. Relation of the neck veins pulsations to respiration. Normally, neck veins will empty with inspiration. During inspiration, there is increased negative intrathoracic pressure, which will cause suction of blood to the lung. So the neck veins will empty during inspiration. This is normal find, but if I find that there is no emptying of neck veins during respiration, I should think of obstruction or severe cause in congestive heart failure or COPD or pleural effusion. But if I find that during inspiration there is filling, so inspiratory filling, while the patient taking inspiration, the neck veins become filled or congested, it is called Kussmaul sign. It is present in constrictive pericarditis and cardiac tamponade. So normally with inspiration there is emptying of neck veins. Hepatojugular reflux, it is done, and we will see it on clinical examination on the patient. It is present by applying pressure over the right upper quadrant while observing the jugular vein. I will do pressure on the right upper quadrant and look for the jugular veins. Normally there is increased filling of the neck veins. I compress on the hepatic vein, causing more blood to pass to the inferior vena cava to the right atrium, and it will pass through superior vena cava to the neck vein. So normally there is increased filling because I am causing pressure. But if there is no increased filling, it means that this pathway is obstructive at certain point. If I apply pressure to the right upper quadrant and there is no increased filling of neck veins, this means that there is obstruction, mostly at the inferior vena cava or superior vena cava or jugular venous obstruction. Relation to cardiac cycle. What is normal? Normally, during systole, there is emptying of neck veins. With systole of the heart, there is emptying of neck veins. How is that? During systole, what is systole? There is ventricular contraction. And while the ventricles are contracted, the atrium at the same time are relaxed and receiving blood. So the neck veins will empty in atrium. During systole, which is ventricular contraction, the atrium will receive blood from the neck veins. So normally there is systolic emitting of neck veins. But if I found that there is, during systole, there is filling of neck veins. So it's abnormal to find that there is filling of neck veins during systole. We might find that during tricuspid regurg, as we described tricuspid regurg, there is inappropriate, that the tricuspid valve will not close appropriately, and it will apply passage, and it will make the blood move back from the ventricle during contraction to the atrium, and it will go to the neck veins. So in tricuspid regurg, we might find systolic filling of neck veins. Also in atrial fibrillation, also if there is junctional rhythm or synchronous contraction in complete heart block. What is meant by synchronous contraction? That the atrium and ventricles contract at the same time against a closed valve. So when the atrium will contract against a contracted ventricle, it will find the valve closed, and it will cause the blood to go back to neck veins and cause it to be filled during systole. Again, to resume, normally there is systolic emitting of neck veins, but if we found there is filling of neck veins during systole, we should think of tricuspid regurg, atrial fibrillation, junctional rhythm, or complete heart block. Special character of jugular venous. Normally there is no special character, but if we found that there is elevated A wave, to understand that we should remember what we understand. A wave is correspond to what? A for atrial contraction. Atrial contraction. So when the A wave will become elevated, when there is a strong atrial contraction, when the atria contracted more. When the atria will contracted more, when there is a pressure in front of the atrium, in the right atrium. When the right, like in pulmonary hypertension, the atrium will contract against to push the blood to the right ventricle and the pulmonary artery. If the pulmonary artery has hypertension, it will cause increased pressure, and the atria will contract against increased pressure. It will increase the atrial contraction, elevate the A wave. The same concept in tricuspid stenosis. The atria will contract, and tricuspid stenosis, it means that the valve is not opened correctly. It is not opened enough. So the atrium will contract against a stenosed valve. It will need more atrial contraction. So this will elevate the A wave. Cannon A wave, cannon, it is like a cannon pole. It means that very strong atrial contraction. When the atria contract against a tricuspid valve, it contracts and the valve is closed. It's completely closed. Like in cases of AV block and ventricular tachycardia. But when the A wave is completely absent, think A wave is atrial contraction. When the atria will not contract, in cases of atrial fibrillation. Atrial fibrillation, the atria will contract at about 20 to 30 to 200 to 300 beats per minute. It is fluttering. There is no powerful atrial contraction, so the A wave is absent. V wave. What is V wave? V wave corresponds to atrial filling of blood. When the atria, so V wave will become elevated when there is more blood in the atrium, like in cases of tricuspid regurg, as we described before. Tricuspid regurg means what? That the valve is not closed properly. During tricuspid regurg, it should be closed, so the atrium will receive blood from the neck veins, and when there is regurg, it will receive blood from also the ventricle. So increased blood or increased filling of blood in the right atrium will cause elevated V wave. Thank you. Good morning, I'm Dr. Muhammad Mamdouh. We will continue our clinical examination regarding face examination and for vital colors examination. At first you should also grade the patient. صباح الخير. ازيك عامل ايه؟ And introduce yourself. أنا دكتور محمد ممدوح. هنفحص بس الوجه بتاعك. During face examination, we will start, to be easier examination, you should start from above and downwards. If there is alopecia, should describe. If there is localized area of alopecia, and it's very important, like in case of this systemic lupus, they have what's called alopecia. And then we should look for if there is any swelling. Here there is a swelling. Mostly it is lipoma, as you see here. Describe what you are seeing. And then we should comment for the eyelid. If there is loss of the outer third of the eyelid, there is no loss of the outer. If there is loss of outer one third, we should suspect leprosy and myxedema. And then we should search for if there is periorbital edema. There is no periorbital edema. And then we examine the patient. There is no xanthelasma. Ask the patient to look upward. Look for the vital colors, pallor and jaundice. There is no pallor, no jaundice, no subconjunctival hemorrhage. Okay. And then we look for the patient nose. If there is a deformity in the patient nose or there is bleeding in the nose, there is no bleeding, no deformity. Then we go for the mouth. Ask the patient to open his mouth. You should look for the patient teeth. There is dental caries. There is no gum hypertrophy. Ask the patient to elevate his tongue. There is no central cyanosis. We should look for central cyanosis. Okay, shukran. There is no gum bleeding. It's very important. The tongue is healthy. There is no signs of vitamin deficiencies. There is no angular stomatitis or herpes simplex. We should look for if there is wasting of the muscles. There is no wasting of muscles at the angle of the mandible. And then we should look for if there is salivary gland. Submandibular salivary gland is not felt. Okay. This is face examination. Thank you. Good morning. I'm Dr. Muhammad Mamdouh. We'll examine today clinical neck veins. I'm lecturer of nephrology and internal medicine. Neck veins, as we described in the lecture, neck veins we should examine for the internal jugular vein. It's better than the external jugular vein. And what are the items to comment for examining neck veins? We should comment on the congestion. It is congested or not, and the level of congestion. It is pulsating or not, relation to cardiac cycle, relation to respiratory cycle, and if there is abnormal pulsations. At first, it is congested or not. How to comment for congestion? We should look for the jugular neck veins and detect the upper level of congestion. It is detected here. And then we put a ruler at the sternal angle. What is the sternal angle? It is the junction between the manubrium and the body of sternum. It is here. This is the ruler. And then we use a paper from the upper level of the neck veins. It is here. To the ruler. It is 3 centimeters above the sternal angle. So the level of congestion is 3 centimeters above the sternal angle. Again, we put the ruler at the sternal angle. We put a paper from the upper level of the congested neck vein or from the level of neck veins to the ruler. So the level of congestion here is 3 centimeters above the sternal angle. This is normal? Yes, this is normal. Normally, the level of congestion, it is up to 3 centimeters or 3 centimeter water above the sternal angle. If it is more than 3 centimeters, it is congested. Second point to comment is it is pulsating or not. Here the neck veins are pulsating. Third one to comment what is relation to cardiac cycle. Normally, there is systolic emitting of neck veins. How to comment for that? By comparing timing with the cardiac cycle. There is systolic emitting of neck veins. After that, we comment on the relation between the neck veins and respiration. Here we find that there is inspiratory emptying of neck veins. There is emptying of neck veins during inspiration. And the last one is there is an abnormal neck vein pulsations or not. There is no neck vein pulsation, abnormal neck vein pulsations. So our comment should include congestion and the level of congestion, pulsating or not, relation to cardiac cycle, relation to respiration, and abnormal. Last one, we can do what is called hepatojugular reflux. Hepatojugular reflux. We palpate the right hypochondrium and look for neck veins. There is increase in congestion while compressing the right upper quadrant, indicating positive hepatojugular reflux. Hepatojugular reflux, when there is increase in congestion, indicating that there is no obstruction, all the pathway, that there is no obstruction in the superior vena cava or jugular veins, while if there is no increase in the congestion of the neck veins, this indicates that there is obstruction in the pathway, either in the jugular veins or in the superior vena cava. Thanks.